Доброго вечора. Українські радіаційні онкологи, медичні фізики, радіаційні терапевтичні технологи. Слава Україні! Дуже дякуємо, що приєдналися до SBRT SRS course with Astro PM experts for Ukraine. Help Ukraine Group, Astro International Committee, PM Clinical Education Subcommittee, Rise Contra Cancer. With speaker support, we are all excited to present this last 11th lecture in the course, and the topic is SBRT for benign indications. Very interesting topic. We have really an excellent and amazing speaker for this topic from Stanford, Professor Erqi Pollom. Dr. Pollom, she's a Sue and Bob McCollum Professor, Vice Chair for Clinical Operations in the Department of Radiation Oncology and Professor by courtesy in the Department of Neurosurgery at Stanford. She's an active clinician scientist specializing in treatment for central nervous system and GI cancers, and led investigation-related clinical trials in advancing multidisciplinary therapeutic approaches to improve patient-centered outcomes for rectal cancer and spine metastases. She has authored more than 150 peer-reviewed publications in impactful scientific journals, including Journal for Clinical Oncology, Journal of the National Cancer Institute, Cancer, Radiology, Neurosurgery, and Red Journal. She also serves as an editor at her specialty journals, including Advances in Radiation Oncology and Red Journal. It's an honor to have you here, Dr. Pollom. We're eager to learn about SBRT for benign indications. Thank you so much for preparing this lecture. The podium is yours. I'll stop sharing.
Okay, great. Yeah, thank you, Natalia, for organizing all of this. That was all the lectures and the course looked really nice. And yeah, thank you for this opportunity to present on benign tumors and using SRS to treat these. So let me see if I can figure out how to share again. Okay.
Looks great.
Okay, great. So we have, for this last session, I'll go over a lot of different things. We have a lot of slides, but I think I should be able to get through everything in the next hour or so, and then we'll have some time at the end for questions. I'm a radiation oncologist at Stanford. I treat CNS as well as GI. With CNS, I do a lot of CyberKnife radiosurgery. GI, I do a lot of SBRT, but I'll be focusing mainly on CNS today and benign tumors in CNS. And there's a lot of variety. That's why I like CNS. We see a lot of weird tumors, a lot of different tumors, and even though these are benign tumors or non-malignant, it's an important treatment because a lot of these tumors, as I will show you, can have a significant impact on patients' lives and can cause a lot of morbidity as well as mortality. And so I think the treatment that we offer is very important for these benign tumors. I just wanted to give a shout out to the CyberKnife CNS RadOnc team, including my mentor, Scott Soltis. He provided a lot of these slides. Also, Al Rahimi, Iris Gibbs. We're a really collaborative and approachable group. So please feel free to reach out to any of us if you have any questions, any interesting cases you want to discuss, or just questions in terms of CNS radiation, radiosurgery. We have a great physics group as well that supports our CyberKnife team, and we work very collaboratively with our neurosurgeons here at Stanford. So the first thing I will discuss today is management of meningioma. I'll probably spend the most time on this because meningiomas are the most common benign CNS tumor. These tumors arise from the arachnoid cap cells. Many patients will have incidental meningiomas, but there are certain things that predispose patients to developing a meningioma, including prior radiation, hormone replacement therapy. These are more common in females, and then there's some genetic syndromes that are linked to meningiomas, including NF2. In terms of how we classify meningiomas, it's basically where they arise from. That's one way in terms of the location. So you can have parasagittal meningiomas. Many meningiomas are just in the convexity. And you can see just kind of locations along the skull base where these meningiomas can arise in any of these locations. In terms of imaging, it's characterized by it's enhancing on imaging, and you can see that many of these meningiomas will have a dural tail. Other diseases with dural tails include chloroma, lymphoma, sarcoid. And then in terms of the other way we classify meningiomas is by pathology grading. And so meningiomas can range from being grade 1, grade 2 to grade 3. This has changed. The grading criteria has changed over the years. This is the most recent WHO grading from 2021. And the grading is based on number of mitotic figures, as well as certain just histology. So for example, with the grade 2s, these will comprise of atypical clear cell choroidoid. If you have an anaplastic or papillary rhabdoid histology, that's considered grade 3. And then there's also some molecular signatures that can move you into a higher grade. And then there's just basically a lot of work now in terms of characterizing these based on molecular signatures and not just, looking under the microscope and looking at mitotic figures. This is just, it can get kind of complicated. One change that I want to emphasize is previously brain invasion was considered grade 2. This is a little controversial. BIOB is brain invasion, otherwise benign. And so now if they don't have any of these other molecular characteristics that upgrade them, and they only have brain invasion, that actually isn't considered grade 2 anymore. And then finally, we can also classify the types of treatments that these meningiomas have. So in terms of the surgeries, often these meningiomas are resected, and in terms of how extensive the resection is, can guide our subsequent adjuvant therapy. So this is the Simpson classification in terms of surgery, where grade 1 is a gross total resection and removal of the dural attachments in abnormal bone. Grade 1 to 3 essentially are varying degrees of gross total resection. And then grade 4 is a subtotal resection. Grade 5 is just a simple biopsy. I thought this is a nice flow chart of our overall treatment paradigms for these tumors. So you'll get an MRI, have a suspected meningioma. If it's not causing any symptoms, no mass effect, observation is a very good option. If it is causing mass effect symptoms, or a lot of patient preference plays into the treatment selection, you can treat it. And treatment can include either surgery or radiation. And then if they do go to surgery, as I mentioned, a lot of the adjuvant therapy will depend on the histology as well as that extent of resection. And so down here, you can see if it's a grade 1 gross totally resected, you're done. You can observe the patient. If it's a subtotal resected grade 1, this is also controversial. You can observe or you can do radiation. If it's a atypical or grade 2 meningioma, gross total resection, observe or do radiation, and I'll talk a little bit about this in some ongoing trials. Grade 2 subtotal resection, we do radiation, and for all grade 3 meningiomas, which is the highest grade, we'll recommend radiation. So a little bit about just doing radiosurgery instead of surgery for these, we have good outcomes with definitive local treatment of these presumed grade 1 meningiomas. Usually these are small tumors diagnosed on imaging. We have good outcomes with using radiosurgery alone. So in this series, tumors were treated to 16 gray median margin dose, and you can see that the 10-year local control was 99%. And well tolerated. This is a trial to be aware of, RTOGO 539, where patients were treated based on their histologic grade as well as extent of resection. So kind of similar to that flow chart in which the low risk patients were observed. So these are grade 1, gross total or subtotal resected tumors. The intermediate group received radiation to 54 gray, and then the high risk group received radiation to 60 gray. And this is the outcome. So for that low risk group, so these are the patients who didn't receive any radiation. The 5-year progression-free survival was high, so 89%. But you can see that for the subtotally resected grade 1, it was not as good as those that had gross total resection. So raising questions in terms of should we be doing something more for the patients who have subtotal resections, even though it was grade 1 meningioma. So this is a subcohort that could potentially benefit from adjuvant therapy. In terms of their intermediate group, so these were the ones with recurrent grade 1 meningiomas or gross totally resected atypical meningiomas. All of these patients had adjuvant radiation, and the 3-year progression-free survival was very good, 94%. When they looked at the recurrent grade 1s or gross totally resected grade 2s, they didn't find a difference in terms of progression-free survival. And then the high-risk group outcomes is interesting. So these are the patients with grade 2 meningiomas, so that are subtotally resected or recurrent, or the grade 3 meningiomas, either newly diagnosed or recurrent. And you can see that the grade 2 recurrent group had pretty poor progression-free survival outcomes, even worse than the grade 3 meningiomas, which suggests, maybe we need to do more to prevent grade 2 meningioma from recurring, because you can see that the progression-free survival for this group is so poor. Most of the recurrences progressed in field. And so, as I mentioned, it is controversial. You have a grade 2 tumor, the surgeon removes all of it. Do you subject the patient to adjuvant radiation or not? There are 2 randomized trials looking at this question. So BN003, randomizing these patients to adjuvant radiation to 59.4 gray and 33 fraction versus observation. And then this is another trial, similarly randomizing patients to 60 gray and 30 fractions versus observation. And then I just keep in mind these doses, right? I just want to bring up this trial because although the data are sparse, many of the CNS radiation oncologists will escalate the dose beyond 60 gray if there is gross grade 2 or 3 residual meningioma. So this is a trial that is treating patients that includes a boost, so a boost to a total of 70 gray. Okay, and then this is another paper that's showing using doses higher than 60 gray is better in terms of treating these atypical and malignant meningiomas. This is another one that shows the local control of these grade 2 meningiomas better if you use doses higher than 60 gray, and then yet another paper that shows this. This is an interesting paper because it also, gives some guidance in terms of the treatment volumes for these grade 2 meningiomas. finding that there are some recurrences that occur in the dura connected to the tumor, and recommending, if feasible, using a 2 to 3 centimeter margin for the CTP. And none of the recurrences occurred in the brain. It occurred more in the dura, so not needing a margin into the brain, mainly having that margin along the dura. So putting it all together, how we approach this currently until we get more of the data from these ongoing trials is for the grade 1 meningiomas. Again, we can observe them. We can do SRS alone, or we can do surgery. If the patients do undergo surgery and have a subtotal resection, we will consider adjuvant radiation if the thought is subsequent growth of the residual tumor will impact function or compromise later treatment options. For the grade 2 meningiomas, actually, for those that are gross totally resected, although it is controversial whether to radiate or observe, we tend towards offering radiation, mainly because of those RTOG 0539 data I showed, where the recurrent grade 2 meningiomas did worse than the grade 3 meningiomas. So again, just kind of erring on trying to do everything to prevent a grade 2 meningioma from recurring. And then for the subtotally resected grade 2 meningioma, we would do radiation. And then again, grade 3 meningioma, they have surgery, and we'll treat all of them with adjuvant radiation. And then, as I mentioned, if there is residual gross tumor, we will try to boost that to beyond 60 gray, because the local control would be expected to be better. So we do 66 gray and 30 fraction. So simultaneous integrated boost to that gross tumor. And then, we talked about how the grading scale has changed over time with the integration of molecular features. I just wanted to include this because there is an ongoing trial at UCSF that is guiding adjuvant radiation based on these genomic risk factors. And finally, wanted to include this image of a patient with a grade 1 meningioma, again, to highlight, these, although they're benign tumors, grade 1 being the lowest, most favorable grade, these tumors can be quite morbid and cause a lot of issues for patients. So it's a very important condition for us to see and treat and help manage. Okay, so Natalia, should we do a poll for this question?
Yeah, absolutely. I will launch it. So if you don't mind reading it, because it's also translating what you're reading.
Oh, yes. Okay, so I'll have some scattered poll questions throughout the talk. That was the meningioma section, so I have a couple of questions. So the first question is, on the BN003 trial, patients with gross total resection of grade 2 meningiomas are randomized to observation versus adjuvant radiation to what dose? A, 50.4 gray, B, 54 gray, C, 59.4 gray, or D, 66 gray?
So we'll wait until 80% answers. So right now it's around 73. Waiting for a few more answers, and I will end the poll. Thank you for answering. I'm ending the poll, sharing results. So majority answered C, 59.4 gray.
Yeah, that's correct.
Good job for listening.
Okay, the next one's a little trickier. Which of the following is a criteria for a grade 3 meningioma? So A is having brain invasion, B, having 20 or more mitotic figures per 10 high-powered fields, C, having clear cell histology, or D, choroid histology. So I flashed through those tables pretty quickly, but we'll see how many folks got it.
Okay, so people are answering. Few more answers, ending the poll. Thank you for answering. So sharing results, majority answered B, 20 more mitotic figures.
That is correct. Good job. All right, let's move on. So next one is vestibular schwannoma. This is another common benign tumor that we treat here at Stanford. These vestibular schwannoma originate in the Schwann cell of the myelin sheath of the vestibular division of cranial nerve 8. And so patients with tumors on this nerve will often present with hearing loss or tinnitus, disequilibrium. Sometimes they can have facial paresthesias or pain if the cranial nerve 7, which runs alongside of cranial nerve 8, is affected, but I rarely see that. I think most commonly I see is patients presenting with hearing loss and just feeling not balanced. 90% of these just affect one side and are sporadic. If patients have bilateral vestibular schwannomas, that's usually an indicator of having that genetic condition of NF2. In terms of how we classify these tumors, we classify tumor size based on KOOS. So just in terms of, you can see this figure here, how much it's kind of protruding out of the IAC and into the CPA and potentially compressing on the brainstem and displacing cranial nerves. We also look at the facial motor nerve function. That's very important when we treat these, to consider the facial nerve, which I'll talk about. And so that dysfunction can range from no dysfunction at all, which is grade 1, normal facial nerve function, to grade 6, which is total paralysis of that facial nerve, which is a very impactful thing because patients then aren't able to close their eyes, they can't move that side of the face. And then finally, hearing is something we think about because a lot of these patients with these tumors can have impaired hearing. It's very important before treatment to have them have audiograms and establish their baseline hearing, determine if they have serviceable hearing that we're trying to preserve. And so this is just that hearing scale where it's based on the PTA and speech discrimination. And so grade 1 and 2 are what we consider to be serviceable hearing. In terms of treatment options, so like meningioma, you can do surgery, radiation, or observation. I'll go a little bit into the data on dose, but at Stanford, we do something a little bit different with our dose. We treat with 18 gray and 3 fractions. I would say the majority of places will just treat with a single fraction, so 12 to 13 gray. So going into surgery, these tumors can be removed, but I thought this was a nice table that outlines, I think, what is the main drawback with surgery is that facial nerve is at risk. And so you can see, although these are older series with older techniques and larger tumors than what we see and treat today, and where they may be trying to get a gross total resection. And so these facial nerve preservation rates are probably poorer than what we see today, but you can see it's a big risk in terms of surgical resection impacting that nerve function. Whereas if you compare this with radiosurgery, I thought this was nice because you can kind of see the progression of the evolution of dose over time. Initially, when we treated to higher doses, we also found impairment of the facial nerve with this treatment. But since then, we've really de-escalated the dose. So with 12.5 to 13 gray, you can see that the risk to the facial nerve is much lower, so less than 1%, much better than surgery, much better than using higher dose. And I think this is probably the biggest advantage with doing radiosurgery for treating these tumors compared to surgery. You can see that after gamma knife radiosurgery, the risks of any long-term complications is exceedingly low. And then this is just a table of other retrospective experiences of radiosurgery using doses from 12 to 15 gray. Local control is very good, so all exceeding 90%, and very low risk of facial nerve damage. Also looking at hearing preservation, you can see that of the patients who had serviceable hearing prior to radiosurgery, the percent who were able to preserve their hearing with the treatment. And I put our Stanford experience with 18 gray and 3 fractions side by side with the single session series I just showed. And you can see our outcomes are comparable. So gray tumor control with 18 gray and 3, 96%. I will note we haven't had any permanent facial nerve damage with this fractionation, so 0%. We have had some trigeminal neuropathy, but you can see that this is very low. And then our hearing preservation is on the higher end of series, so 76% of patients who had serviceable hearing prior to radiosurgery were able to preserve their hearing after 18 gray and 3. And so because, we think these data are a little bit better compared to some of what is out there, we have stuck with 18 gray and 3 fraction as our preferred regimen here at Stanford. This will come up, we'll see patients who don't have a lot of symptoms, have an incidentally diagnosed small meningioma small vestibular schwannoma. And the question would be, do we need to treat this or can we continue to watch? It's controversial because only in this series, in this meta-analysis, you can see that only 40 to 60% of these tumors will grow, and that hearing loss is not correlated with tumor growth. And so, it's kind of not clear what is better in terms of treating now or treating later. This is one retrospective series where they looked at an observation versus treating with a gamma knife and found that observation was associated with a higher risk of progressive hearing loss. And so the argument, the conclusion of this paper is if hearing preservation is important to the patient, then they should get early treatment. But again, this is, a retrospective study with biases and limitation, and we haven't had any prospective randomized studies until recently. So this is a randomized trial that was recently published in JAMA that randomized patients with small to medium-sized vestibular schwannoma to a 12 gray radiosurgery versus observation. And not surprisingly, this study found that patients who undergo SRS had better local control. But interestingly, when they looked at all of the secondary endpoints in terms of hearing, balance, quality of life, they found no difference in terms of the observation versus upfront radiosurgery arms. This is in contrast to the VISA study. This is through the International Radiosurgery Research Foundation, where data from participating centers were collected retrospectively. And these are for, again, smaller vestibular schwannoma, so KOOS grade 1 and 2. And they just compared those who elected to undergo radiosurgery versus observation. And like the randomized trial I just showed, this study showed that patients who had radiosurgery had better tumor control rates compared to observation, so not surprising. But in contrast to the VREX study, this study showed that radiosurgery was associated with actually lower risk of symptoms such as tinnitus, vestibular dysfunction, and cranial nerve palsy. And there was a nice editorial just kind of trying to understand, the differences in these findings. Again, this is a retrospective study, but I think one of the reasons why these two studies may have found different results is for the VISUS population, these were smaller tumors. Patients were less likely to be symptomatic at baseline. And so the thought is it's better, you will have find more of a beneficial impact of treatment if you treat early. And then finally, one thing to be aware of is when we do treat these tumors, they can swell after the treatment, and this does not mean that the treatment didn't work. So this is a series where patients had radiosurgery for vestibular schwannomas and found that 14% had initial tumor enlargement after radiosurgery. The most of these, the swelling was transient, and the patients did not have continued enlargement. So just because these tumors look larger after the treatment does not mean it's a local failure. Usually we'll continue to watch. And this is another paper that characterizes in more detail the dynamics of how the tumor volume changes after Gamma knife. You can see there's all these different patterns. So this is a nice chart where on the y-axis is the tumor volume trajectory over time, so years on the x-axis. And you can see these patterns where for patterns 1, 3, 5, and 4, actually pattern 4 after the treatment, there's no swelling. So there's some patients where the tumor just immediately shrinks or is stable after the treatment. But for patterns 5, 3, and 1, you have that initial bump or increase in volume. And as you continue to follow these patients, that volume, that enlargement will start to subside. And then pattern 2 is the pattern of actual recurrence, where patients will have that gradual increase in volume and it will persist. And so the key is, you can have kind of a range of volume increases after radiosurgery at different time periods, and don't call it a local failure or repeat radiosurgery until after 5 years. Okay, so that was vestibular schwannomas. I just have one question for this section. Which of the below choices most closely approximates the risk of damage to the facial nerve with using SRS 18 gray and 3 fractions for treating vestibular schwannomas? Is it A, 0%, B, 5%, C, 10%, or D, 20%?
And Archie, these were patient-reported toxicity, when they are compared, like, let's say, rates of tinnitus and others, hearing loss.
Yeah. Yes, exactly. So they have validated instruments where, patients
reported it.
Yeah.
And it depends at which stage you report it, right? Because if the tumor enlarges right after, you might have worse symptoms, right?
That's a good point. Yeah, that's a good point.
Okay, so we have 88% answering. I'm ending the poll, sharing results. So the most used answer was B, 5%.
Yeah, so we're actually better, 0%.
0.
Yeah.
Yeah. Okay.
All right.
Stop
Great.
sharing.
Okay. So the next condition we commonly use radiosurgery for is trigeminal neuralgia. And what this is, just using the International Classification of Headache Disorders definition. So trigeminal neuralgia is when patients have these recurrent unilateral facial pain episodes and the distribution of one or more divisions of the trigeminal nerve. And then listed here are just some of the other diagnostic criteria. The nature of this pain is usually it's pretty quick, so lasting from a fraction of 1 to 2 minutes. It can be very severe. Patients will often characterize it as an electric shock-like pain, or just a feeling of shooting, stabbing, sharp pain. And it can be triggered by any kind of stimuli in that area. So patients will often say eating, brushing their teeth will bring on the pain on that side of the face. And it can be pretty debilitating. I just saw a patient in clinic where, she's just avoided eating on that side of the mouth for years and years because she's afraid of triggering a pain episode. So she just eats using the right side. And then D is not better accounted for any other diagnosis. And then here you can have, you can characterize the pain intensity on the scale from 1 to 5. This is just a reminder of the trigeminal nerve. It, comes off of the surface of the pons, goes through Meckel's cave. That's where the sensory ganglion sits, and it supplies sensory sensation to the face, as well as sensation and motor to the muscles of mastication. And the trigeminal nerve has these segments where you have the dorsal root entry zone, then the mid-cisternal section, and then the retrogastrian section. So going from proximal to distal along the nerve. In terms of causes of trigeminal neuralgia, many of the cases are actually caused by just a vessel compressing the nerve root, or sometimes I've seen tumor there compressing the nerve, and that can result in focal demyelination, causing pain. Multiple sclerosis can also cause this. Usually the symptoms are bilateral and not just, affecting one side. You can have brainstem lesions, you can have central sensitization. And so with classical trigeminal neuralgia, these are the patients we'll most often see. These are the patients who have trigeminal neuralgia without any cause other than potentially a vessel compressing, whereas the secondary trigeminal neuralgias are due to things like multiple sclerosis or tumor compression. And in terms of how to treat this, most of these will initially be treated with medical management. And then those that are refractory to medical management or patients cannot tolerate the medications, then we'll consider them for local procedures such as microvascular decompression, rhizotomy, or radiosurgery. This is just an overview of medical management. First-line treatments, carbamazepine, and it's pretty effective. We have trials that show that this medication can reduce the intensity and frequency of attacks. However, a lot of patients have trouble tolerating this medication. You can have drowsiness, dizziness, nausea, vomiting. It can affect your labs. And then I've just listed some of the other medications that patients often can try to help with this pain. And then in terms of local therapy options, so microvascular decompression is good, when it's clear that the pain is caused from a vessel pressing on the nerve. And so this does involve a craniotomy and removal or separation of the vascular structures from the trigeminal nerve. It is effective, so patients will have pain relief. And you can see that the pain-free rates are pretty good. However, again, it's, a surgery, a craniotomy, and you can have complications from the surgery. Other local therapies can include ablative procedures. So going through the foramen ovale at the skull base and basically ablating that trigeminal nerve root or ganglion. It can also be effective for pain relief you can see good pain-free rate. However, this is, again, an invasive procedure. It has complications. And I will note it has a 4% anesthesia dolorosa complication with these ablative procedures. And this is something that a complication we fear with trigeminal neuralgia treatment, where the patients can actually have worse pain. It's a different kind of pain after treatment. It's persistent, painful numbness in that affected region, and can be very debilitating and considered worse than even the pain of classic trigeminal neuralgia. So in terms of radiosurgery, we have a lot of experience with using radiosurgery to treat that nerve and help with pain. This is a nice systematic review showing that 85 to 90% of patients have freedom from pain after radiosurgery, though patients do have pain recurrence. And then this is our Stanford series, where again, we found the procedure to be effective for 85% of patients. I will note that it does take some time for the procedure to work. So I would always warn patients, when you have the radiosurgery, don't expect the pain to improve overnight. It can take about a month to have relief. And then in terms of, durability, I will say I typically counsel patients, 50% chance of the pain coming back in the next 3 years. But I do have patients who go long-term without needing a retreatment. And then the main potential side effect we'll counsel them on that's most common is facial numbness. In terms of the technique, the goal is to obtain post-irradiation hypoesthesia, but not get to the point of having anesthesia dolorosa. And so, we talk about numbness as a side effect, and I'll show some data, but we found that the chance of numbness is very correlated with the effectiveness and durability of that pain relief. So numbness is correlated with pain relief, which supports the theory that SRS just injures the trigeminal nerve fibers in a non-selective fashion. And there's different targets that you can use. We target the dorsal root entry zone. This is most common, and this is where the radiosensitive oligodendrocytes transition to the more resistant Schwann cells. There are other places that will target a little bit more distally in the retrogastric portion of the nerve. And this is just a comparison of different targets where A is where you're targeting more distally. The advantage of this is you have less brainstem dose, and then we target more posteriorly, so a little bit closer to the brainstem. And this is just some data showing that, you have better outcomes with higher dose, but you have more numbness as well. So looking at 70 gray to 90 gray over the years in terms of, pain relief percentages, and it increases, but you have that numbness increases with higher dose. So again, just showing how numbness is correlated with pain relief. In terms of planning, we get a Fiesta MRI. So very important to have a nice thin slice T2 MRI where you can really visualize well the trigeminal nerve. So this is just the Fiesta here that I'm showing, and you can see that left trigeminal nerve very well. We also get CT with contrast, and again, we target the dorsal root entry zone at the level of the pons. So we put our target 3 millimeters off the pons. It's about 5 millimeters in length, and it ends up being a volume of about 25 to 30 cubic millimeters. And then in terms of dose, we prescribe 6-2 gray and 1 fraction to the 80% isodose line. So that makes the Dmax 75 gray. And then these are just some of the considerations when we look at a CyberKnife plan for this. We want to make sure that enough beams are used. So using over 100 beams, this is just another check to make sure we're not having, high intermediate dose unnecessarily kind of spilling to other parts of the brain. We use our smallest collimator, which is the 5 millimeter one. That's the smallest we have for CyberKnife. And then in terms of our OARs, we watch out for the brainstem. So trying to limit the brainstem to Dmax of 25 gray because the lateral cortical spinal tract runs there. And, damage of this will result in a lot of issues. We also contour out our cochlea, our cranial nerve 7 and 8, just to make sure that high dose isn't going through that. Also keeping an eye on the temporal lobe. And then just as another double check, we will turn on kind of the lower doses to make sure nothing weird is going on with the 8 to 10 gray isodose line. It's not like going through the chiasm or something like that. Okay, so that's trigeminal neuralgia. We'll keep on going. Lots of topics. AVM, I'll be brief about AVM. So this is another common benign condition that we treat with radiosurgery. It's a congenital condition that's characterized by an abnormal connection between the arteries and veins. And it basically appears as this tangled mass of small blood vessels. And the main issue with AVMs is they can bleed. So this is an oversimplification, but I think good to just it makes it easy to remember. So AVMs have about a 3% per year risk of bleed. If patients already have had a bleed in their AVM and they come to see us, then we predict that the risk of the AVM rebleeding is much higher, so 30% per year. If they have a bleed, then up to 30% risk of dying. And then once we treat these with SRS, it takes about 3 years for the AVM to obliterate and that risk of bleeding to go away. And so AVMs can occur in any part of the body, including the brain and spinal cord. And in terms of determining treatment for this, we have to consider kind of life expectancy, right? So if it's a younger patient, then they have many, many years of life. And so their lifetime risk of bleed is much higher than someone older. So just keeping that in mind when we counsel patients in terms of the risks and benefit of treating their AVM. This is a nice paper that shows even though it takes years for the AVM to kind of obliterate after radiosurgery, this shows that there is an immediate improvement in that risk of bleeding. So we use these numbers to counsel patients, even if the AVM has not yet obliterated after radiosurgery, that risk of bleeding goes down by 50% immediately after radiosurgery. These are the doses that we typically use. So, higher doses, more effective in terms of obliteration. You can see 16 gray, 70% obliteration, up to 20 gray, 85% obliteration. But this is balanced by radiation necrosis. So these are the Flickinger curves that we often use, where we look at the V12, so volume receiving 12 gray or more. And the important thing to note is this is actually including the AVM volume. So it's not, brain minus AVM volume. It's this includes the AVM volume. So the larger the AVM you treat, the higher dose you treat it to, the more risk of having symptomatic radiation necrosis. And this is also kind of dependent on the location of the AVM in terms of if it's pons, midbrain, or thalamus. So these are charts that we kind of look at. This is the main thing that will limit our dose. And so for the larger AVMs, it gets tricky, right? Because how do you deliver an effective dose to maximize the obliteration rate while being safe in terms of symptomatic radiation necrosis? We have sometimes fractionated the dose of the AVM. Sometimes we'll volume stage it. So where we kind of split the AVM in half and treat one half of the AVM to single fraction, and then the patient comes back 3 months later, and then we'll treat the other half at that point. Okay, so another question about AVMs, what is the typical time frame of AVM obliteration after SRS? A, immediately, B, 6 months, C, about 3 years, or D, longer than 10 years?
Okay, so we have 80% answering. I'm ending the poll, sharing results. So majority answered B, 6 months.
So 3 years. It
3
takes
years.
longer, unfortunately. But the reassuring thing, as I mentioned, is the hemorrhage risk is reduced even before the
immediately, 50%.
Yeah, even if the AVM, before the AVM is completely obliterated. Okay, I'll keep on moving. I know it's a lot of topics. Paraganglioma. So these are super rare tumors, but I wanted to include this because I think it's just a good case of, you know, like many of these benign tumors, it's historically been treated with surgery, but I do think radiosurgery is a much better option. So again, these are rare neuroendocrine tumors that arise from the paraganglion, and many of these are located in the head and neck region, so at the skull base. And the symptoms depend on the tumor's location. It can include just having a neck mass, having hearing loss, tinnitus, or cranial nerve deficit. And as I mentioned, you know, surgical resection has historically been the mainstay of treatment, but as you can imagine, it can have a lot of impact on the patients because you're doing resection in an area that has a lot of nerves and vessels, and it's high risk of patients having neuro deficits after the surgery and that having a significant impact on their life. So radiosurgery is actually something we have been doing more and more for these tumors. And it's a little bit of a controversial point, but I would say as many people at Stanford may argue that it should be the standard of care treatment for these paragangliomas rather than surgical resection. And so just showing some data, this is a review of 37 studies looking at radiosurgery to treat head and neck paragangliomas. Local control was excellent. And of the papers that had both surgery and radiation, the review found that surgery was more frequently associated with neurodeficits, not surprising, than radiation and had a lower chance of local tumor control. This is another kind of review of 19 studies of radiosurgery treating glomus jugulare tumors. Again, very good tumor control, symptom control. Another review of carotid body paragangliomas, where radiotherapy had just as good long-term control as surgery, but 0% permanent cranial nerve deficits compared to 22% for surgery. Again, this is, you know, our Stanford series showing similar things in terms of excellent local control and preservation of facial nerve function and hearing status. With these patients, it's important to follow them long term. Like many benign tumors, you know, I have to counsel my patients, compared to surgery, don't expect the tumors to disappear after radiation. They're not going to melt away. What we're looking for is stability, but we do see with time, with longer follow-up, there is regression in many of these tumors in terms of the tumor size and volume. And then I just wanted to show, this is a tumor where multimodal imaging is so important to make sure we're not missing tumor when we treat. So you can see this is a left skull base paraganglioma you can see on the MRI. And if you just use the MRI, you would underestimate the extent of the tumor, because if you get a dotatate PET, which is highly sensitive and specific for this type of tumor, you can see the tumor is not only at the skull base, but kind of going all the way down in the neck. And so if you just had one type of imaging, you would miss all of this tumor going down the neck. So just highlighting the importance of having good imaging, multimodal imaging to help delineate an accurate target when you are treating so precisely with radiosurgery. Some example plants. This is one paraganglioma we treated with CyberKnife radiosurgery, 14 gray and 1 fraction. You can see after the treatment, you can see the treatment-related change in the tumor with internal necrosis. This is another large skull-based tumor that we treated 21 gray and 3 fractions. So, you know, not really a kind of stringent size cutoff for being able to treat these patients with radiosurgery. It's more just, seeing what we can keep the OAR's dose down to. And then these are just common radiation doses we use for paragangliomas. So wanted to highlight this specific type of tumor just to demonstrate that, radiosurgery is a really excellent surgical alternative in terms of being effective at controlling these tumors, being much more well tolerated for patients. So briefly, just wanted to end with future directions. I'll try to fly through these. So one thing that we are using radiosurgery for is to treat essential tremor. This is the most common movement disorder. There's lots of different treatments that patients can try. So medication, physical therapy, deep brain stimulation, which is basically like implanting a device similar to a pacemaker where a thin wire or electrode is implanted in the thalamus that sends electric pulses to disrupt this tremor-causing signals. You can do MRI-guided focused ultrasound, which uses high-intensity focused ultrasound waves guided by an MRI to create a lesion in a specific part of the thalamus to try to improve tremors. And then you can do radiosurgery. So with radiosurgery, how we do this is we deliver 130 gray and a single fraction to the ventral intermediate nucleus of the thalamus. And that's the part of the brain involved in motor control. And you can see, that's where this plan is targeting. It's that what we call the VIM. And just for the sake of time, I've included, a YouTube video that goes more in detail in terms of how to localize this area and the planning. But so far, you can see just in terms of all the studies of using SRS for tremor, you can see the doses used, very high doses, and tremor improvement percent, you can see very, very good. The other thing that we're using radiosurgery for is helping with cancer-related pain. So this is a very relevant indication for many of our patients in radiation oncology. Control of cancer-related pain is an unmet need. There have been earlier studies of using surgery or chemicals to ablate the pituitary, which has demonstrated high pain relief, but as you can imagine, high toxicity. So there has been a lot of interest in non-invasive methods, including using radiosurgery to target that pituitary stalk to help with pain relief. And there have been small studies, again, using very high doses that targeting that radiosurgery can provide rapid pain relief and very low rates of diabetes insipidus. So a table of all of the studies so far looking at this, you can see the doses used as well as the high rates of pain relief following this radiosurgery procedure. And I just wanted to highlight, this is a trial that we have at Stanford that will be looking further at using radiosurgery to improve pain in these patients. And it's going to be a randomized trial where patients will be randomized to radiosurgery, 160 gray and 1 fraction to sham radiation. And they'll be looking at pain response. And this is the target. So 160 gray to the junction of the pituitary stalk with the pituitary gland. Another trial I wanted to highlight is at Stanford, we're also interested in using SABR for treating cardiac arrhythmia. So this was a case study that one of our faculty published of using 25 gray and 1 fraction to treat ventricular tachycardia. This was in 2012. And the dose basically targeted this area of scar that was the origin of this arrhythmia, and the patient tolerated it well, required no sedation for this treatment, had no complications, and follow-up ICD interrogations revealed a decrease in total VT episodes. And so this group is similarly now looking at using SABR to treat atrial fibrillation, so another type of cardiac arrhythmia, but this is an important condition because it affects over 50 million people worldwide, and advanced age is a major risk factor, so incidence is expected to be rising. And the thought is it originates in the, well, so it's in terms of the pattern, it's a regular, very rapid heart rhythm, and thought to originate at the pulmonary vein. And so, you know, currently we're using catheter ablation like cryoballoon or radiofrequency to treat ablation. But as you can imagine, a lot of patients are older and poor candidates for this type of procedure. And so this is the rationale for using SBRT, which is it's non-invasive, better tolerated for higher risk patients, shorter treatment time. You avoid the risk of ablation procedural complications. We have some clinical studies of this, but what our group's trial is proposing is using our V-Ray machine to better target the area. So you can see, you know, using V-Ray, the target is much smaller than if we didn't use V-Ray, because they have to use a bigger margin. And this is important because the targets for AFib is close to the esophagus. And the thought is, you know, it can be less toxic. And then finally, lower back pain, another prevalent condition where we've published our results in terms of using radiosurgery to lesion the nerves that innervate the facet joint and help with back pain. So 40 gray in one session to that intra-articular surface of the facet, we targeted that. And did find that some patients benefited from this and no toxicity. So yeah, lots of exciting, you know, possibilities for using radiosurgery for these conditions as well. And this is my last question. What is the radiosurgical target for essential tremor? A, cranial nerve 5, B, ventral intermediate nucleus, C, ventral internal capsule, or D, pituitary stalk?
Actually, this is my favorite lecture. It's packed with so much information and it's very interesting.
Yeah, well, I was going to say thank you for everyone for staying on through this. This is over awesome. 100 slides, so I appreciate everyone staying on till the end.
And it's also impressive how big of a role Stanford played in all of this, right?
Yeah.
Lots of trials. Interesting. Thank you for highlighting it. Okay, excellent. So we have 81% of participants answering. And in the poll, sharing results, majority said B.
Yes, yay, that is correct.
Great job listening. Okay, yeah. We have a lot of questions in the chat. Thank you so much for such an interesting, exciting lecture. So I'm going to read out the questions so people have can see the translation also into Ukrainian. Thank you for a very interesting lecture. What dose and fractionation do you usually use for re-irradiation in cases of recurrent vestibular schwannomas?
Yeah, that's a great question. So first, again, just emphasizing waiting before jumping to retreatment, right? Because a lot of these patients can have, you saw the different patterns of volume changes. Many of these patients can have these transient volume increases, and it can be years after the radiosurgery. That does not mean it's a local failure. If you continue to follow these patients, sometimes, the volume will start decreasing again. So I think the first thing before putting a patient through retreatment is really following them, being patient, and making sure that it really is a local failure. Now, if it is a local failure, we actually just recommend the same dose, so 18 gray and 3 fractions. We've looked at our retreatment series and found that the control is similar with, retreating with the same approach, which, made us think like maybe it's just kind of a stochastic, like failure just because it didn't work the first time, maybe due to chance. So just do the same thing. And we find that that's well tolerated. I know there's some concerns with reirradiation, but we still think that's better tolerated than a surgery.
And Archie, how long do you follow them until you decide, until you say, oh, this is the failure?
Yeah, so I mean, the data that I showed would suggest probably waiting for 5 years.
Oh, that's a long time.
Yeah, but yeah, we do follow these patients long term. Initially, it's like scans with every 6 months. If everything looks good, you can space it out, but you do sometimes have late failure, so it's very important to follow patients long term.
Okay, thank you. Excellent. So we have a question from Sergei Filkovsky. What's the dose constraint for OARs in trigeminal neuralgia with CyberKnife? Brainstem Dmax 25. Can I ask what protocol this is based on, and what protocol do you generally follow for treating trigeminal neuralgia?
Yeah, great question. So that's what we're doing nowadays. And this is more based on our experience. So in the past, we let the brainstem Dmax go to higher, like 40 gray, and we found much higher rates of just toxicity. Because again, that lateral cortical spinal tract runs along the brainstem in that area. And so based on prior experience, we've dialed down the dose a little bit and try to keep the brainstem Dmax to 25 gray. It's easier actually for some older patients where there's more space sometimes, and that more space, it's a little harder for younger patients sometimes to meet that if there's less space, right, in terms of where the trigeminal nerve is.
Okay, thank you. Dr. Sokolowska has a question. Dear Dr. Pollom, thank you so much for your fantastic presentation. The possibilities of treating skull-based tumors given such a complex anatomical location are truly impressive. Which late side effects are most commonly observed after SBRT SRS, myelopathy, radiation-induced neuropathy? How often is irradiation performed?
Yeah, that's just going to be very different in terms of where you're treating. I will say myelopathy and radiation-induced neuropathy is very rare with the way we do radiation. So I would say, that's just very, very unlikely if you respect the spinal cord constraints. But yeah, I think it's just going to be different depending on where you're treating. For example, with, let's see, like, what do we talk about? Like a vestibular schwannoma. Maybe the most common thing I see is, that transient swelling, which can cause symptoms. You worry about the dose to the cochlea, so you can have kind of hearing loss from the radiation, though that's also a little debatable, right? Just in terms of some of the data showing maybe just preventing the tumor from growing, treating it is better at preserving hearing loss than, the concern of radiation causing hearing loss. But yeah, I think it's just going to depend on
location,
where you're treating.
Where you're treating.
Yeah.
Okay, thank you. Thank you so much for a very interesting lecture. A question from Dr. Burek. Do you perform radiosurgery for AVM after partial endovascular embolization? And how do you define the target? Nidus only, or do you include the embolized component? And what dose fractionation do you typically use in this setting?
Yeah, that's something we actually have been doing more of, where patients will get at least part of the AVM. This is helpful for larger AVMs. Part of the AVMs will be embolized, and then we just treat the residual. So I wouldn't cover the parts that's been embolized. We would just treat the residual. It's all about trying to limit that B12 as much as possible. So if it's been embolized, I will take it, and that helps make the target volume smaller. And then I don't change my dose. So, if there's a residual nidus, I would just treat it similarly in terms of trying to get the dose as high as possible while being safe. And then, I think the thing that comes up for larger AVMs is whether to fractionate or do volume staging.
How do you make that decision?
Yeah, I've tended to try to stick to single fraction. And so if it's large enough, then my preference would be to volume stage it so that I can keep the dose still single fraction.
And do you have a cutoff in volume?
Not really.
Not really.
Yeah, I can't think of it off the top of my head, but you'll be able to tell, for the big ones, it's like, we're not going to meet the V12.
I see. So you're basically worrying mostly about normal brain.
Yeah.
Dr. Burek, you want to follow up with a question?
Yeah, thank you very much. Thank you very much. We also have a lot of experience of cyberknife AVM treatment in our clinic, and in Ukraine also we had. But we have the dose stage, and we had the dose stage treatment, the dose stage treatment, and it was in 12 grays 2 times, 24 grays in and we can irradiate all. We can irradiate even the large AVMs, but we exclude the embolized material.
Yeah, so the same.
Yeah. Yeah, sounds similar to what we do. We will. I don't think it's clear, right? I think we have, for the larger ones, treated like something fractionated, like 27-3 or something like that. And it's kind of controversial in terms of if, fractionating it will be as effective as just doing a single fraction dose. So we've done both. That's something that we're actually in the middle of looking at, is just of our large AVMs, comparing the two approaches. It's retrospective, but we're trying to do some dosimetric analysis in terms of if there's a difference between fractionating it or just trying to keep it at single fraction and volume staging.
And when you stage, what time interval do you usually allow?
3 months.
3 months. Okay.
Yeah.
Okay, another question is from Nadia Honcharenko. Thank you so much for your great talk. About cardiac arrhythmia, do you treat patients who has already been treated with standard treatment, or SABR is alternative treatment? And what are the results of trials?
Well, I mean, that's something we're trying to do, right? At Stanford, we haven't treated these patients on trials. I think Bill's actually in the process of trying to open 2 trials for this. One is MRI guided, and the other one's in collaboration with Varian. But we need more data. I think a lot of the studies have, I just showed a few, but are very small. And it seems promising and effective. But I think it's particularly good for patients who aren't able to tolerate invasive procedures. And a lot of these patients, right, with cardiac arrhythmia have a lot of comorbidities or elderly. So I think this is a potentially promising treatment.
Yeah, very nice. I think WashU has some experience, and University of San Diego, California.
Yeah.
It's just challenging to control the heart motion. How do you deal with it?
Yeah,
Is the frame rate fast enough to capture the heart motion?
Yeah, they'll have to work that out.
Okay, sounds good. Amazing lecture, Erqi. Thank you so much. It was really incredible. And thank you, everyone, for joining in and listening, answering all the questions correctly. We will have a post-course survey and also test, so please fill it out to get your certificate. Thank you again. It was amazing. Thank you.
Thank you. Thanks, everyone. Bye.
Bye-bye.